So, you think you know diabetic drugs? Well, anti-diabetic drugs. Very few people get a perfect score, so let's see how well you can do and start with question 1. But first, you should know that each question will have explanations right after. But don't worry, there will be timestamps on this video so you can easily find and answer each question. Let's start with question 1. Which of the following drugs can cause weight gain? A. Miglatol, B. Sitagliptin, C. Rosiglitazone, or D. Exenatide? And the answer is option C, rosiglitazone. So, sitagliptin is actually a DPP-4 inhibitor and they are weight neutral, while exenatide is a GLP-1 analog and it actually causes weight loss. Of the options here, the best answer is option C. Rosiglitazone belongs to a group or drug class called glitazones. How we can remember that it is associated with weight gain is by this, the glutinous zone. It kind of sounds like glitazone, and of course gluttonous means someone who overindulges. So that's one easy way that we can remember this very high yield association. But the glitazones aren't the only drug class that belongs to this gluttonous zone. Sulfonylureas also are associated with weight gain. So I truly hope that this gluttonous zone helps you to remember the drug classes that are associated with weight gain. Now let's move on to question number 2. A patient with diabetes mellitus is experiencing recurrent urinary tract infections. What is the mechanism of action of the drug that could be causing this? A. Inhibits hepatic gluconeogenesis. B. Increases glucose-dependent insulin release. C. Decreases postprandial hyperglycemia. Or D. Inhibits reabsorption of glucose in the proximal convoluted tubules. And if you know the answer, you can go ahead and skip to the third question. If not, let's look at the explanation. Well, first we have to know which drug class does which mechanism of action. So option A relates to biguanides or metformin. Option B relates to DPP-4 inhibitors. C. Alpha-glucoside inhibitors, and D. SGL2 inhibitors. So now that we correlated the drug class to each of these mechanisms of action, then which one do you think is the answer? If you said option D, you are correct. It's so important for you to know that SGLT2 inhibitors inhibit the reabsorption of glucose in the proximal convoluted tubules. These SGLT2 inhibitors often have the flow in their names or flowzin. You can use this flow to think about the flow of water or more specifically the flow of urine because these flowzins can cause UTIs and glucosuria. And because these SGLT2 inhibitors act at the PCT or the proximal convoluted tubule, then we have to know that we should use them with caution in patients with renal insufficiency. Another important adverse effect of SGLT2 inhibitors is that it can be associated with dehydration and possibly even leading to orthostatic hypotension. Question 3. What drug should be discontinued prior to surgery? A. SGLT2 inhibitors. B. Biguanides. C. DPP-4 inhibitors. Or D. GLP-1 analogs. And the answer is option B, biguanides. So metformin is a biguanide, and it's very important that this is discontinued at least 48 hours before surgery because severe lactic acidosis can occur due to surgical stress. So lactic acidosis is the most high-yield fact about metformin and possibly for anti-diabetic drugs overall. So it's very important that you remember this. So, like I said before, metformin is a biguanide, and we can remember that metformin is associated with lactic acidosis with this, the METs. So the MET in metformin and the MET in metabolic acidosis. Because of this feared complication of lactic acidosis is another reason why metformin is also discontinued prior to doing a CT with contrast. If a patient develops lactic acidosis, this can be life-threatening. So it's very important that we discontinue metformin prior to surgery and prior to a CT with contrast. So 3 questions down, and I truly hope that you are doing very well so far. And if you are enjoying this content, be sure to power up that like button, hit subscribe, and that notification bell so that you never miss another high-yield video. It also lets me know if I should create even more videos like this. Now let's move on to question number 4. A 41-year-old female who was recently diagnosed with diabetes mellitus presents with vomiting, headache, and blurry vision. Her temperature is 100 degrees Celsius, pulse rate 121 beats per minute, blood pressure 100/60, and respiratory rate of 20. This started after having wine with her friends. What drug is most likely responsible for her presentation? A. Glyburide, B. Tolbutamide, C. Liraglutide, or D. Acarbose? And the answer here is option B, tolbutamide. So option C is a GLP-1 analog. So to answer this question correctly, we have to know what this patient is experiencing. So they developed some pretty strange symptoms after drinking some wine, and those symptoms included vomiting, headache, and blurry vision. She also seems to have some alterations in some of her vital signs here. So this patient is most likely experiencing a disulfiram-like reaction. So we have to know which drug class can cause this. And that is the sulfonylureas. To be specific, the first generation sulfonylureas. It's important that you know this because option A and option B are both sulfonylureas. However, glyburide is a second generation sulfonylurea, while option B, tolbutamide, is a first generation sulfonylurea. So that's why option B is the answer. And remember that disulfiram-like reactions can present with headaches, blurry visions, facial flushing, vomiting, hypotension when they are taking the sulfonylurea with alcohol. So that's why these symptoms occurred after drinking wine with her friends. So we can use the FIR in disulfiram-like reaction and first generation sulfonylureas to remember the correlation between those two. And examples of first generation sulfonylureas include chlorpropamide and tolbutamide. And just to check that you've been listening so far, I want you to leave the answer to this question in the comments section below. And that question is, prior to which imaging procedure should metformin be discontinued? Leave it in the comment section below. I'll wait while you type. And you're typing. Okay, great, thank you. Let's move on. Question number 5. A 71-year-old male with a history of diabetes mellitus for 15 years recently started a new oral anti-diabetic drug. He presents with sweating, palpitations, and nausea. What drug is he most likely taking? A. Metformin, B. Sitagliptin, C. Glyburide, or D. Dapagliflozin? So here we have an elderly male experiencing symptoms of hypoglycemia, such as his sweating, palpitations, and nausea. So we have to know which anti-diabetic drug is more likely to cause hypoglycemia in the elderly. And the answer here is option C, glyburide, which is a sulfonylurea. So I have other drug classes listed here. So the big one is DPP4 inhibitor, SGLT2 inhibitors. So those aren't commonly associated with hypoglycemia in elderly patients. However, sulfonylureas definitely are. So this is the second high-yield association with sulfonylureas. The first one talking about the disulfiram-like reaction, and now this, the hypoglycemia, especially in elderly patients. So remember that. And now we're on to question number 6, and I hope that you're getting all the questions so far. And if not, that's fine. I at least hope that you're learning and getting some high-yield points from this video. So let's move on to question number 6. What adverse effect is most likely to occur in someone taking linagliptin? A. GI upset, B. Nasopharyngitis, C. Lactic acidosis, or D. Hypoglycemia. So the gliptins are DPP4 inhibitors, and one of the most common most highly tested adverse effects of these gliptins is nasopharyngitis. So that is the answer. GI upset and lactic acidosis most commonly occurs in patients taking metformin. GI upset can also occur in patients taking alpha glucosidase inhibitors as well. And of course, hypoglycemia occurs in sulfonylureas like we just discussed. So that would leave us with option B, nasopharyngitis. Now, this slide is basically showing you a nice little summary of DPP4 inhibitors' adverse effects. And those include respiratory and urinary infections. So yes, we discussed that the flozins can cause UTIs, but DPP4 inhibitors can also cause urinary infections. So DPP4 inhibitors are also weight neutral. And we are now 6 questions down, and if you haven't liked this video yet, please power up that like button, hit subscribe, and that notification bell. It really lets me know what types of videos you like so that I can make more. And if you have any other video ideas or topics that you'd like me to discuss, you can always leave them in the comment section below. Now let's go to question number 7. A patient known to have diabetes mellitus presents with epigastric pain that radiates to the back, nausea, vomiting, and elevated amylase and lipase. What is the mechanism of action of the drug that can cause this? A. Increased glucose-dependent insulin release. B. Inhibits reabsorption of glucose in the proximal convoluted tubule. C. Decrease postprandial hyperglycemia. Or D. Inhibits hepatic gluconeogenesis. If you know the answer, just go ahead and skip to question number 8. If not, that's fine. Let's look to the explanation. So this patient most likely has pancreatitis because of their clinical symptoms. So we have to know which antidiabetic drug can cause pancreatitis. So let's correlate these mechanisms of action with the respective drug classes. So option A is describing GLP-1 analogs, B. SGLT2 inhibitors, C. Alpha glucosidase inhibitor, or D. Biguanides. And the answer here is option A, the GLP-1 analogs. So it's very important that you know that GLP analogs can cause nausea, vomiting, weight loss, and pancreatitis. Extremely high yield. Question number 8. Let's go. Which drug can increase the risk of fractures? A. Dapagliflozin, B. Rosiglitazone, C. Liraglutide, or D. Metformin. So the answer here is option B, rosiglitazone. And remember the gluttonous zone that we mentioned before? So the side effects, one of the side effects of glitazones is weight gain. And remember that sulfonylureas are also in the glutinous zone because they also cause weight gain. However, another important adverse effect of glitazones is increased risk of fractures. All the other drugs mentioned as answer choices for this question are also high yield, so let's do a quick review. So remember that dapagliflozin is an SGLT2 inhibitor, and its very high yield adverse effects are UTIs, dehydration that can even lead to orthostatic hypotension. Liraglutides, they are GLP-1 analogs, and they can cause pancreatitis, nausea and vomiting, as well as weight loss. Metformin is a biguanide, and it can lead to lactic acidosis. Therefore, it should be discontinued prior to surgery and CT with contrast. And lastly, it can also cause GI upset. So let's do a quick review of glitazones. So all glitazones can cause weight gain, heart failure, and increased risk of fractures. So there is a special type of glitazone called rosiglitazone, and this specifically increases the risk of myocardial infarctions and cardiovascular death. If you are enjoying this active review of anti-diabetic drugs, be sure to power up that like button, hit subscribe, and that notification bell. Now let's move on to question number 9. A patient presents with nausea, vomiting, sweating, and irritability. Plasma levels reveal elevated insulin and C-peptide. What is the mechanism of action of the drug that most likely caused this? A. Closed calcium channels in pancreatic B-cell membrane. Open calcium channels in pancreatic B-cell membrane. Delayed carbohydrate absorption. Or D. Decreased glucagon release. So again, this patient is experiencing symptoms of hypoglycemia with nausea, vomiting, sweating, and irritability. So we already know that sulfonylureas can cause this, but the question is, what is the mechanism of action of the sulfonylureas? Well, let's look at the answer choices. So option A is the action of sulfonylureas. Option B is a distractor. Option C is a mechanism of action of alpha glucosidase inhibitors. And option D is a mechanism of action of amylin analogs. So of course, that means that option A is the answer. So please note that sulfonylureas can lead to an elevated C-peptide and an elevated insulin. Okay, so let's just take a step back and look at sulfonylureas. So like I said before, the mechanism of action is that they close calcium channels in the pancreatic B-cell membrane. This causes the cell to depolarize, thus causing insulin to release via an increase in calcium influx. But there are some very high yield adverse reactions. Of course, we already discussed all of these, but let's just recap. First one, disulfiram-like reaction. Remember, this occurs in first-generation sulfonylureas such as tolbutamide and chlorpropamide. And remember that disulfiram-like reactions occur when the patient drinks alcohol with their medication. It can cause headaches, blurred vision, facial flushing, vomiting, and hypotension. Another side effect is hypoglycemia that is especially seen in elderly patients. They can also have weight gain because remember, the glutinous zone, we have the glitazones and the sulfonylureas are also there. And of course, high plasma insulin and C-peptide levels. And here we are at our final question, question number 10. A 37-year-old female with diabetes mellitus presents with vaginal discharge and pruritus. She has had 3 vaginal infections since starting her new medication. What is the mechanism of action of the drug that can cause this? A. Increased glucose-dependent insulin release. B. Inhibit reabsorption of glucose in the proximal convoluted tubule. C. Decreased postprandial hyperglycemia. Or D. Inhibits hepatic gluconeogenesis. So this patient is having recurrent vaginal infections due to some anti-diabetic drug. So which diabetic drug is associated with vaginal infections? And that is SGLT2 inhibitors. So we have to know which one of these mechanisms of action relates to SGLT2 inhibitors. And that is option B. They inhibit reabsorption of glucose in the proximal convoluted tubules. We discussed very high yield adverse reactions of SGLT2 inhibitors. These include UTIs, dehydration leading to orthostatic hypotension, weight loss, and even hyperkalemia. And this last adverse reaction that we will discuss is that it can cause vulvovaginal candidiasis. Also, remember that because of its mechanism of action in the kidneys, we should use with caution in patients with renal insufficiency. And that brings us to the end of our quiz on anti-diabetic drugs. So let me know in the comments below, what was your score? How much did you get correct out of 10? But of course, this video on anti-diabetic drugs would not be complete without discussing insulin. One of the most common ways to be tested on insulin is with this graph that shows the plasma insulin level versus the hours. Okay, so of course here we see all the different types of insulin. It's very important for you to know that the different types of insulin, well, specifically the ones labeled in black, they are given at meal times to replicate postprandial insulin secretion. And as you can see, they are the rapid acting types of insulin. And then in blue, we have the regular insulin. And we usually give an IV infusion of regular insulin to treat patients with DKA because this allows for rapid adjustments in the dose based on the glucose levels. So we give IV insulin and not subcutaneous insulin because subcutaneous insulin starts working within 30 minutes, which is definitely not fast enough. Patients taking insulin can also have an increase in their appetite. So it's very important that they receive counseling to let them know that this is a possible side effect. And then we have all these different other types of insulin, like the long-acting types. So how can we remember all of this? Well, we can do that with this mnemonic. And that is lag, rest now, don't go. Lag, of course, relates to the rapid acting insulin. Rest now, don't go, regular NPH, Detamir, and Glargine. So those are very, very, very important for you to know. But of course, there are two Gs, well, two types of insulin with Gs. So we can distinguish between these two Gs with the large and Glargine. So that large means like a large half-life. So that lets us know that Glargine is way over the other end over here. So that is the longer acting G. So remember, lag, rest now, don't go. Lag, rest now, don't go. And there you have it, our very, very high yield review and quiz on anti-diabetic drugs. Remember, let me know in the comment section below what was your score on the quiz. And if you enjoyed this content, be sure to power up the like button, hit subscribe, and that notification bell so that you never ever ever miss another video. And to continue learning more, you can click this video right here. Okay, thank you so much for watching until the end. Bye!